Now I would like to call Dr. Rajesh Joshi sir about the preoperative workup because the preoperative work is very important before the cataract surgery. So over to you, sir.
On the preoperative evaluation in cataract surgery to get crisp and clear vision. The aim of the preoperative evaluation is to have assessment about the ocular and systemic health, identify any potential risk factor that may affect surgical outcome, optimize patient's visual outcome after surgery, and educate about the surgery and manage the post-operative expectations. The ocular history is the most important part of the examination. Previous intraocular diseases, injuries, other eye cataract surgery need to be known so that you can modify the intraocular lens power accordingly. The systemic history in the form of diabetes mellitus, hypertension, current medications are important, particularly in those patients who are taking alpha blockers. They may have floppy iris syndrome during the surgery. If the patients are on antiplatelet agents, they need not be stopped nowadays because we are performing clear corneal incisions. But you must know whether they are on antiplatelets or not, and whether they are on long-term steroids or not. These things should be seen clearly. If the patient has got acute dacryocystitis, ectropion, they should be corrected before you take these patients for the surgery. Slit lamp examination is the prime importance while you perform the cataract surgery because they may have some endothelial deposits, keratic precipitates, and corneal opacities. The endothelial count, if you have access to specular microscopy, you must do the endothelial count because sometimes endothelial may look healthy but they have such type of problems, guttata under retroillumination or endothelial polymorphism, that should be taken into consideration. Now pterygium, if in many Indian rural patients they have pterygium coexisting with cataract also. So, and with high expectations, you must tell them that you may have a suboptimal outcome because of the corneal opacities, particularly patients having such type of pterygium. Now I will take this case scenario. 60-year-old female with cataract and pterygium. Patient wants premium IOL. How to proceed further? The patient has got steep curvature. You can see here and on the topography. And the effect of pterygium on corneal abrasions, everyone knows that they induce corneal abrasion, and once you remove the pterygium, they may get reduced. So we perform pterygium surgery first in this patient and then cataract later on. The patient was kept on lubricating drops for 3 months because patient may have dry surface post-operatively. Now about the keratometry. Ideally, you should measure keratometry more than by one instruments, and it should be reliable and repeatable. Anterior chamber, particularly shallow in intumescent cataract and anterior subluxated lenses, that should be taken into consideration. It may be deep in myopia or subluxated lenses. Gonioscopy, if you find some abnormalities, they should be seen, and accordingly you can modify your surgical steps. Particularly in shallow chamber, you may have to use high molecular weight viscoelastic, protective endothelial viscoelastics. Now reaction of the pupil, if patient has got RAPD, then that suggests that some retinal pathology. Whether the pupil is dilating or not, that should also be considered because you may have to use iris hooks or iris expanders during surgery. Morphology of the lens should be taken into consideration. If it is a brown black cataract, and if you think that you may not be able to do by phacoemulsification, you can consider removing them by small incision cataract surgery. Posterior polar cataract with obvious dehiscence, they may create problem intraoperatively, so that should be explained in the preoperative session only, that you may have dehiscence, may have to undergo second surgery if something goes wrong. Retinal examination should be done in each and every case. Biometry, as Dr. Harbanslal has suggested, you must do it properly, and the requirements are keratometry, axial length, and IOL calculating formula, IOL power calculation formulas. Keratometry, you may consider manually, auto keratometer, topography, or optically, but optical biometry is the gold standard nowadays. The sources of error in the biometry could be poor fixation, dry eye, or irregular corneas. 1 diopter of error in the measurement will cause 0.9 diopter of refractive error post-operatively. Measurement of the axial length, the present gold standard is by optical biometer. But if you don't have access to optical biometer, you can always consider doing it by immersion scan, because that is again gives accurate reading. Now tips for accurate measurement of the axial length: ensure that machine is calibrated well. Echoes from cornea and anterior lens and posterior lens surface are perfect, and there should not be, you should not push onto the cornea, particularly if you are using the applanation biometer, because it can cause error post-operatively. These are the types of various formulas which can use in various eyes. If you have hypermetrop eyes, you can use Barrett Universal 2 or Hill RBF formula, but the most accurate one is the Barrett Universal 2 formula. Toric or non-toric. This is another case scenario. 58-year-old male having epithelial basement membrane disease with K reading of 45 vertical and 47 horizontal. This was the dilemma whether to put toric IOL or to treat this basement membrane disease and then go again for IOL power, and then whether to consider this patient for toric or non-toric. So we debrided this epithelium which was loose. The K reading was improved to 44.5 and 45. So this was treated with monofocal IOL. Another patient having dry eye, having same problem. The biometry changed from 20.5 to 18.5 diopter because of treatment for dry eye. So big no to premium IOL if patient has got severe dry eye. So conclusion, preoperative evaluation is very important each and every case, and counseling before cataract surgery must for crisp and clear vision. Thanks for your patience listening.
Thank you, sir.